our experiences with the conversion to telehealth pre-COVID, during COVID, and what we expect the future to look like. And we have great representation kind of in the southern triangle of Ohio. So those of us from Ohio State and Columbus, we have Dr. Reiling from Premier Health in Dayton, and Abigail and Melissa speaking to us from down in Cincinnati. Maybe it's warmer down here. So if I could start with my UC Health friends, if you could just do a quick introduction, and then Dr. Reiling will have you do an introduction, and then we'll kind of start into our panel discussion.
I'm Abigail. I'm the director of telehealth at UC Health. I've been here 3 years, and I moved into the director role, I say, just in time for COVID in February. So it's been an interesting experience. Before that, I had some clinical and administrative experience, several years at Christ Hospital.
Hi, everyone. I'm Melissa Harper. I'm the IT manager at UC Health. I support multiple teams, including Epic Ambulatory, Epic Security, and Clinical Documentation Services. With Ambulatory, I also support MyChart and all telehealth initiatives from the IT perspective, and work very closely with Abigail.
Okay, and I'm Walt Reiling. I'm the CMIO for Premier Health in Dayton. I'm a family physician by background and do still work clinically 1 day a week. I've been working in IT at least part-time since 2002 and full-time as the CMIO at Premier since 2012.
And Dory.
Hi, good morning. I'm Dory Klemansky. I'm the service line administrator for cancer support services at the James Cancer Hospital. I am also a nurse practitioner.
All right. Thanks, everyone. So we'll jump in, and I'm going to try to keep an eye on the Q&A as we go on. But and just so everyone knows, we are also recording this session so that those who couldn't participate are able to join at another time. At least hear what we had to say, but not ask questions. All right, let's see if I can get my slides to advance on Zoom. So here is all of us again. This is a collaborative effort between our three organizations, which is very exciting. So this we're kind of just going to kind of talk through each of our organizations and kind of where we were before the pandemic. And if it's okay, I'm going to start with, just because I'm already talking, and Dory has got a lot of great experience. If I could start us off with Ohio State, and Dory, from your perspective, kind of where were we with telehealth sort of pre-pandemic? What are your thoughts as an administrator and also as a provider?
Sure. So when we were working towards telehealth, it was still a relatively new initiative. We'd had pieces and parts throughout the health system at Ohio State for quite some time. There was infrastructure already in place, but it was sort of a niche area on the cancer side where in support services between survivorship and palliative, we were really starting to pilot it, and we'd actually done just under 100 visits at that time, trying to see what worked and what didn't. We also have some e-consults throughout the health service system. And at that time, though, we were struggling, as a lot of institutions were, with reimbursement models and how are we going to address where geographic locations, and could we really do this? And it was sort of a novel niche at that time. There were plans, and still are, for more advanced telehealth surveillance and remote monitoring. But at that time, it was a pretty new endeavor at the James.
Dr. Reiling, how about
so at Premier, we were in a very similar place. As you know, we had very little use of telehealth, although we had a fair amount of technology available to us prior to the pandemic coming online. And So we were limited, as was noted by the reimbursement models, which really were not very complementary to virtual health of any sort. And we're focused on a few use case needs where the benefit outweighed the potential costs involved. We had a pretty robust telestroke program where we would leverage our neurology specialists out across the community to help with evaluation of for TPA in the case of acute stroke. We did have a moderately successful e-visit program, which is the asynchronous text-based visits through MyChart in our EMR, which was self-pay for the patients primarily. And we did also have a sort of a virtual urgent care, as was in place in a lot of locations that was pretty much self-pay. And we did a little bit of remote monitoring, a little bit of behavioral health through telemedicine as well, but very limited in terms of volume and scope based on the reimbursement models primarily.
Abby and Melissa, how about your pre-pandemic view at UC Health?
Yeah, so same themes here at UC Health. We also had reimbursement challenges. So we tried to focus on the Medicaid reimbursement. So programs who had high volumes of Medicaid patients, how could we implement telehealth in those areas? We also had e-visits set up for primary care, and we were starting the discussions for e-consults, which kind of got put on hold during the PHE, and then we did implement during the PHE. We also we've had some experience with patient monitoring. We have used a vendor at one point, and then we also tried doing it on our own. We called it a turnkey program through Epic, and it didn't work out very well, so that stopped. And we were doing. Are we going through all the technology too, or just strategy? Sorry.
You can do whatever you like.
So we were using the Epic MyChart video visits. We had deep integration, and it was fine for low volumes at the time. And we did have MyChart bedside set up. It's only set up at one of our locations, and at low volumes, obviously for video visits at 1%. Our stroke volumes were a little bit higher because that was more of an established program, and we had reimbursement.
And Melissa, you're probably one of our true IT perspectives on here. What did it look like from your angle?
Pre-COVID, it's just as Abigail stated, we really didn't have a lot of volume of usage, even though that we had the technology available for our providers to use. It just wasn't widely adopted at the time. So, I think it's probably pretty much the same scenario as every other organization. And obviously everything changed with COVID.
So the one question I have, and this is just coming from my own personal experience at Ohio State, is, around governance. We spent probably a good solid year trying to sort of figure out who should be involved, and a mix of IT and a mix of clinical and revenue cycle. How did you have similar challenges pre-COVID with kind of putting together your governance structure for telehealth?
Definitely we did. And I have to say that in some ways we're still struggling today. We do have a MyChart steering committee, which is actually very well received and very much attended from a lot of different areas throughout the organization. It's IT, it's some clinical, it's some providers, it's billing, it's legal compliance. So, we do, encompass the whole gamut of representation, to support our patients, including patient experience department with MyChart. The problem is that it's a work group, not necessarily a committee or a high level decision-making group. So, we recommend, and then we will move initiatives forward, whether it's to our ambulatory informatics committee. But then there again, who has the responsibility of the true governance and the true executive level decision making. And that's something we're still working through today. I think we've done a great job with what we've had through, pre, during, and post COVID right now, but we're actually still working on that executive level of governance.
So, Dr. Riley, so you have a C in front of your name. What does that look like from your angle?
Well, I think that's very similar, and we also have had issues in terms of figuring out how to establish this. We as I kind of alluded to earlier, we've attacked specific use cases, and so in that scenario, most of these programs sort of sprung up as work groups around a problem, and that sort of is where the governance in each case lied, and it was sort of siloed. So our telestroke program did a lot of their own work around how they set things up and did things. We do have a limited EICU program. We have other things like that where they've basically all kind of been almost freestanding with us in IT sort of in the background trying to keep all the synergies together. But from an operational standpoint, they've been very fragmented. And it's a little hard for us because, and I think it's true for all healthcare organizations, this is a little bit different than our typical models because these things touch so many different areas. They affect providers and patients and nursing staff. They affect different pieces of the organization kind of simultaneously. So establishing a governance structure has been very challenging.
So it sounds like, all of us have had, a taste of telehealth, so to speak, kind of pre-COVID. And Dory, you were kind of one of the pioneers, I guess is probably the best word, at least within the cancer program, kind of in the support services. Can you just speak briefly to, your experience with it? And you had some very supportive providers in the areas, and probably that less than 1% of total office visits were your areas.
Sure. So the health system at large had a structure already with a medical director for the telehealth program, and he was very invested in the telestroke program and with the forensic inmate telehealth program. So that was already there. It took 6 to 9 months to even progress to the point where we could start these, just due to the system constraints at that time. We had to go through multiple committees to get approval. Then we all had to go through 30 minutes to an hour training of how to use Epic for my. It was just a really long, slow process to get to that point. But we were really lucky that all of the providers that work in our service line were really open to this. I think we were one of the first areas that really raised our hand to ask, could we do it? Particularly because, survivorship and palliative care are really important constructs, but it's not in the same vein as trying to ascertain how to do a new patient oncology visit or a chemo visit. So we were sort of well positioned to do that. We had trialed about 75 patients through the Epic MyChart to be able to do it with patients. We learned some good lessons in that. There wasn't a lot of infrastructure for patient-facing education on how to do MyChart. So our providers were spending a ton of time trying to teach patients how to download the app, how to get onto MyChart. And it was just, it was a real learning curve to figure out how to help the patients actually do the video visit in addition to seeing them for clinical care. So that was probably, besides reimbursement, that was one of our biggest challenges, was just trying to get the patients up to speed on how to do it. And Epic has a really robust program, but it's a complex program for providers and patients to learn how to do a video visit through.
So that's a really great segue into, let me see if I can get my slide to go here. A great segue into actual response, because what Dory is mentioning, I'm sure, is something that was a challenge kind of during, as we responded. So sort of the day that will live in infamy for in my own head is when our chief medical officer called me on March 12th and said, I need you and the 2 clinical informatics medical directors to help stand up telehealth within the James Cancer Hospital and work with IT and work with the rest of the medical center to make that happen. Go. I think probably all of us on the panel and who are attending probably have that date or right around there in mind. So, as Dory mentioned, at the James anyway, we had very limited exposure to this. So just we don't do primary care, we don't do telestroke, and really that little pocket that Dory's talking about for palliative care and survivorship is the small specialty area where we had video visits started, and as she alluded to, a handful to a dozen or so, prior. So our experience with telehealth prior was minimal at best, and as you all mentioned, we were really struggling with the governance around this and who to involve and how to get this up and running. But March 12th hit. And so I can tell you from our experience, it was obviously an explosion, and it was, how do we get cameras to our exam spaces and to our providers? How do we, from an IT perspective, make sure that we were using and still continue to use video as our Epic integration, and so expanding on the licenses for that and working with our IT colleagues to get that. But it was beyond that as well, and it's how do we, so things like Haiku and Canto we could use for our providers, but we couldn't necessarily do that for nurses. So our organization stood up UpDocs in pretty rapid succession, and that allowed for our nurses, our social workers, all of our patient support care staff to be involved in video visits as well. And we really went from, kind of that less than 1% to about 20% of our office visits in our ambulatory areas being done via video or phone. And, prior to this conversation, Abigail and I had, she was like, really, that's that low? But it's important to point out that the James is a cancer specialty hospital, so it's not necessarily reflective of the broader experience for primary care, general med surg, and those sorts of things. So I can see from Premier and UC Health that those numbers are considerably higher. So I think the biggest challenge, and I see there's a few folks from my own team, was finding out who needed cameras. We didn't have telehealth set up, so we had to push software, push cameras, get them set up, expand the use of Haiku and Canto. A lot of questions about iPads and can I get a new iPad and can I get this on my phone to start using that? I'm sure Melissa was having to deal with that, and Abigail. But even more than that was the workflow redesign, and it is how do you, particularly in a cancer environment where it is, oops, my apologies. Where there is more than one person that typically sees the patient. And so how do you incorporate, the technology with those workflows so that the social worker, the nurse can start the visit and assess the patient before handing off to the doc. The social worker or the oncology rehab, et cetera, can, participate in that visit. So lots going on there. I think we'd be remiss without focusing also on our inpatient setting and how did we work to set that up. I think everybody had mentioned MyChart Bedside. So, using the tablets that we already have existing. Fortunately, at OSU, we have those rolled out system-wide, but we kind of had to use the clunky ways of using WebEx for virtual rounding. and for visitors to be able to connect with their loved ones in the hospital. So that's a little bit of our experience at the James. I could probably go into considerably more detail, but so how about UC and Premier? What are your similar? I'm sure very similar, but
yes, so you see how similar challenges. We were also using Video Connect, and at the beginning, Video Connect integrated with Epic, and at the beginning we had challenges like managing our licenses. So we had a certain set amount of licenses that we purchased, and we were trying to manage how many do we need? Do we purchase a bulk amount? How do we know if we're going to be using them? Sometimes we would go over, and then eventually Video Connect allowed for us to have a buffer. And so we had purchased 2 sets of additional licenses, and one was a 3-month agreement. So when that 3-month agreement was up, it just happened to be that Epic then had their own solution. They're calling it Epic Native Client, that we did switch to that. It happened to be at the exact same time I think it was July or the end of July. We did that. And we did have some inpatient workflows. We're using Video Connect through context-aware linking, and it didn't really uptake because it was very cumbersome. There were a lot of steps to it. So we ended up just using Video Connect outside of Epic for some of those communications. At the same time, we also rolled out Teams for the organization, and then we started using that for telehealth purposes. So the virtual rounding in the hospital settings, support groups. When we did transition to Epic Native, we did lose the ability to do multiple provider visits as well as multiple patient visits, where we were able to do that before with video, and then we couldn't. So we had to spin up now a new workflow using Teams, and a combination of Teams with MyChart or Teams with emailing for multiple providers to visit either a single patient or multiple patients. And this was important for us because we're a teaching hospital. So we needed to have a way for the residents and the preceptor to be on a call together, and they were, usually in separate locations. In the hospital, we did deploy, in addition to the our Westchester location had MyChart Bedside, we used social apps like Google Duo. So during visitor restrictions, patients could communicate with their family members, to prevent social isolation and have conversation. Also a way for providers to connect with families in those end of life care type scenarios, because the families couldn't come in to see patients in the ICU. So we were using it for that purpose too. And, now we're not at that, same scenario anymore. But same as you, Rob, at the James, we deployed tablets, expanded Haiku and Canto use, and obviously a lot of workflow redesign. In our volumes, that's an inclusion of e-visits, phone visits, video visits in all specialties. So that's including hospital-based like PT, OT, SLP, and now we're doing cardiac and pulmonary rehab.
So our experience was, obviously very, very similar. I think, in the time after that magical day you mentioned earlier in March, we launched a program really in about 2 weeks that as Dory mentioned, probably should have taken 9 or 10 months to get in place. And it became sort of an all of the above strategy, which, in talking with other CMIOs around the country, pretty much everybody has. I've not found a single place that has a one video solution setup. You have to do different things to meet different needs, and we were certainly no exception to that. We had the context-aware linking with a Cisco that was brand new that we were using, but we quickly learned that some patients were not able to utilize that because they didn't have MyChart. Some of the technology on the patient end just wasn't up to the robust video streams that the Cisco system demanded early on. And so we quickly added in for those patient and provider visits that we were replacing with from the office, a standalone Doxy.me solution, which allowed the providers and the patients to essentially set up a video presence session completely outside of Epic and do the video in that manner, which worked fairly well. But our ultimate goal has been and continues to be to make the virtual visit as much like a real in-person visit as we can. So we want to allow for those prep portions of the visit to happen via video, and do things that are very, very similar to what we would do in an in-person visit to make the experience better for both the patient and for provider and staff. So we're moving down the road of the Epic integrated solution, which allows for some of those things for us to be happening down the road. They're obviously, like every other vendor, working on enhancing capabilities at a pretty rapid rate. And so, we anticipate we'll be closer and closer to that as time goes forward. We had to do a lot of things with hardware. We didn't have, we did essentially in primary care in most of our specialty offices, 0 video visits. So we had essentially 0 cameras, 0 microphones, 0, everything. So we had to try to get that. And guess what? Nobody had any because everybody in the country was doing the same thing. So it was a real struggle for us to get this stuff up and running. And we did leverage a lot of people's personal tablets and iPhones and whatnot to get those video pieces working in those early days. But we're much more organized now. We were up at a point there in the peak in April of doing 50% of our visits virtually. We're much lower than that right now. We are still seeing the vast majority of our patients in person as of today, but as things change over the next weeks and months ahead, we anticipate we'll be certainly maybe not back to 50%, but a much higher percentage that will be virtual. So we're preparing for that as our next phase.
So for Dory and Dr. Riley, you both see patients also. Can you describe a little bit, during this, especially kind of the peak of things, what was the patient response to this? Like Dory mentioned, even pre-pandemic, the challenges with trying to connect patients, and we'll talk a little bit more about that in general, but I'd love to hear your perspective from a provider standpoint. How is it connecting, and what do you have to do differently to connect with patients using this technology? Especially since, as healthcare providers, it's a very touch heavy, it's a very, for lack of a better term, physical experience to be able to properly assess a patient. So it just, from your perspective, how has that changed that, and what's your perspective?
So I think that the patients really understood. I mean, we're all aware of what was happening with the global pandemic. And I think for the most part, they were really willing to sort of go along for the ride with us on what we needed to do, and really didn't give a lot of pushback on converting to video visits. I think the challenge came from us, particularly around the difficulty getting them to connect through Epic or things like that. So when our institution allowed us to do Doximity or UpDocs, it really opened the landscape, because then it reduced sort of the level of complexity it took to get the patients onto the visit. We literally sent a text message through a link, and then they were able to get on. So once we were able to do that, it definitely eased what happened as the patient experience, and we got a lot more positive feedback from that. We certainly try to use Epic when we can, but I would say that particularly during a lot of the uncertainty, we tended to default to some other mechanisms, because it really would be disruptive to us as clinicians trying to get to patients, and you couldn't connect and what was happening. And so when we were allowed to use other platforms, it made the patient experience a little bit easier. I don't know what Dr. Riling's thoughts are on that. But.
Yeah, no, I think, and again, I think it was a real learning experience, both for the patients and for us as providers, and how to make this work and how to do it efficiently. I think early on we were seeing about a 50% failure rate on the videos in terms of people where we had to switch over and just call them on the phone, or they'd be on there and we'd see them,
exactly.
No audio and all these things. But the patients, just like us, are now much more well versed in using video. They're doing it with their families, and the beginning, especially the older patients, we would get we'd see their forehead and that was it, and they're much better at that. One of my associates is a sports medicine physician, and so I saw a lot of his patients during this time, and these were mostly people between 15 and 25, and they were really adept at this. They would if you wanted to look in their throat, they would get their phone out and they would shine the camera with a light right in there, and you could see about as well as when they were in the office. And so what I'm learning how to help coax the patient into doing the right thing to help me to see what I need to see. They're learning how to use the technology and understand how a camera and microphone work together. And so that's been a real enlightening experience. And I do think it really opens the door for us down the road to use this technology in a much better way going forward.
I think we learned a lot too. We don't have all the answers yet, but around some sort of like decision trees or algorithms or what are the best patients to use for visit. It's not right in every scenario for every patient. But I think we learned a lot in the last 6 months that will really be able to inform us going forward of how to use this in a non-pandemic state of what we can and can't do. I do think I felt lucky as a provider that our institution created a way for us to still be able to chart and log our schedules through Epic, even though it was third party, whether it was Doximity or UpDocs or some other thing. They created an appointment type for us so that our schedules weren't messed up by having a MyChart video visit versus an outside vendor. So they created an appointment type for us that was third party, so we could keep our schedules and keep everything aligned and organized for us. So that was really useful as a provider. And then it helped us make sure that we stayed on our workflow with patients.
Yeah, that's a really great call out, Dory. And I think probably some of our patient access and scheduling staff are really some unsung heroes for helping with a lot of the workflow. They had to be really involved. And as Dory mentioned, being able to so our providers weren't bouncing back and forth between, in-person video, and trying to aggregate those. And even going so far as to trying to, distinguish between an Epic MyChart visits versus a third party, making those distinctions in there so that it was easier for the providers. It's interesting because I know that, prior to our going, we had many providers who were saying, no way, no how would I ever have, any kind of video visits. And interesting, some of those same providers during the midst of the pandemic, and even probably to this day, now only want to see their patients via video, which is pretty interesting. Melissa, I'm wondering if you might, speak to some of the challenges that you may have had to deal with associated with the technology. So bandwidth and things like that, Abigail had mentioned, the licensing piece and making sure that we had enough, but sometimes it was the connection or the network would, be an issue. What sort of challenges did you face from that perspective?
We faced a lot of challenges from the IT side. With the platform that we were using, which was the video solution. Even pre-COVID, we did not have a whole lot of luck using Warp Drive and being able to, connect to the external hardware with PC laptop use. So we focused on using mobile devices and encouraged mobile device use. Early on, we were only able to use iOS. So when COVID hit, there was a mass, we need to do video visits. We could identifying which providers have personal iOS devices and which providers do not. It just so happened that from a previous initiative, Abigail had about 100 old iPods in a closet that we decided to dig out. And it was actually a huge initiative. Actually, my Epic ambulatory analysts actually were pulled in to assist with testing the devices, setting everything up, loading Haiku. We have a mobile device management platform that our client services team, loaded all these quickly and actually used the analysts to go out and deploy these devices to the providers that needed them, do at the elbow training for the providers of how to even do video visits. We put packets together. So it was a big collaborative effort to get everything out there. Now, in the interim, we did have to do a lot of beefing up of our access points for Wi-Fi. So using all of these devices, these mobile devices, did cause a little bit of I guess you would say, a bogged down, right, of the bandwidth. So our network services guys were on it, and they went out to a lot of our locations and made sure whether we had to add new access points or they had to work with our vendors and just beef that up so that it could handle the volume and the bandwidth that was going through. You know, like everything else, you know, we've transitioned along the way, and moving to the Epic native platform gave us a great ability to then use Android devices. We're actually now just in the process of rolling out PC hardware and external webcam devices. And as everyone knows, it's painful because everybody wants this hardware. So a lot of things are on backlog. You know, we need iPads, we need carts, we need, you know, all these devices to be deployed. So it was definitely a big collaborative effort to get everything done, and the teams worked really well together.
Yeah, I would echo the ability of the teams to work closely. So, you know, in my personal experiences, I have a team of 10 nurses that worked very closely with our IT colleagues to help identify, you know, where cameras needed to be, and actually, you know, kind of at the elbow support to help with, you know, how do you get through a video visit? And it's not just the technology piece. It's also, where do I document? How do I document? You know, this looks different to me. We're going to talk in a minute about some of the challenges associated with that. But, you know, I think our team's got all kinds of crazy questions. It's we got a lot of questions about billing, which we'll talk about here in a little bit, and I'm sure Dr. Riling has hopefully has some expertise that he can tell us a little bit about that. But you know, the questions, it was amazing how engaged everyone became because they wanted to do the right thing. They wanted to make sure they were using the right technology that was allowed, and they wanted to make sure that they were billing appropriately so that their patients weren't overbilled, and making sure they were covered and those sorts of things. So it was really impressive on that. And I don't think that any one of us or any one group had the answers, but I think the collaboration around getting the answers was really unique to this experience. So in the interest of time, I'm going to move us to, you know, what does the future look like, you know, for our respective organizations? And I wanted to look a little bit at challenges, and you know, kind of focus on these three areas around regulation, payer uncertainty, supply chain, and workflow. I'll flip back to that in just a second, but you know, where do we think we're going? What's next? I will say from our experience at the Ohio State, and I think this expands just beyond our cancer hospital, is we're a little bit in limbo right now. I think you know, you can see that our visits have fallen off considerably, although I think we're still in a much better place than we were. We're doing pretty nicely with you know, being able to visualize our data now, knowing, you know, which of our patients are being seen via telehealth, and those providers and specialties that are providing those services. We've done a lot to standardize our workflows and the technology that we have in-house, and we have not implemented the Epic solution yet, but it's definitely something that we're looking at. But I do also think it's picking up kind of where we left off, and be it good or bad, there's been a dramatic slowdown, you know, I think from the peak, although given kind of our current situation, that may pick back up again. But I think it's looking, you know, how do we, for us at OSU, it's the Epic video integration. It's how do we further capitalize on our third-party video integrations, you know, specifically UpDocs and Teams. Remote patient monitoring is not something that we really started to do, but we're dipping a toe in the water there. So that's that's where we are. But I think a big expansion is really kind of everybody is sort of holding their breath and waiting to see what happens with the regulatory and payer environment. And so would just be curious as to everyone else's thoughts. And, Dory and Dr. Reiling, you both bill for services, and, what are your challenges, around that? And what do you foresee in the future? And it's not just necessarily just that, but it's also, practicing, beyond our borders, because I think all three of our organizations are tertiary medical facilities that see patients out of state. So what are your thoughts?
Well, I think you touched on a lot of it. There is a lot of uncertainty around where things will land with the, as we touched on at the very, very beginning of this discussion, reimbursement drives everything really, because you can't do it if there's not a way to get paid for it. And we, are optimistic that there will be some ongoing changes outside of the pandemic environment that will allow us to continue to do this. I think there's enough feedback from patients that they're going to, really want to continue to have this option when it's appropriate. My thing has always been that the long-term biggest benefit comes in telehealth comes not from the urgent care sort of environment that we really were doing before, but really merging this into our chronic care management strategies and the ability to not so much replace office visits with video visits, but to augment them and use this as a way to keep in closer touch with those chronic patients that need that ongoing care. We're looking at, how does this fit in with our organizational goals in regard to patient engagement and a whole strategy around, our websites and our patient portal and all of these things, and how do they play nice together and make for a seamless quality experience for the patients. You touched on patient monitoring. We have a home care organization as part of Premier that does that, and we will continue to do, I think, more of it. But we do want to make those visits really as much like being seen in person as we can. And I think that's going to be our goal, is to continue to make this look and feel as much like an in-person visit and merge it into our holistic picture of how we take care of our patients the best on an ongoing basis. And that opens the door for the value-based payment models in terms of how we can also be reimbursed for that care.
I don't have much more to add to that. Between Rob and Dr. Reiling saying all of that, that's exactly what we experience as providers. We're waiting to see, not just from, CMS and private payers, but, regulatory bodies, state boards, about what we can do. I have a lot of staff in my practice that are in my service line that are not just physicians or nurse practitioners. They're, behavioral health and PT, OT, and how are those going to be affected, because we did do those types of things too. So I think we're just waiting to see what the landscape will look like going into the future. The CMS physician proposed fee scale kind of demonstrates that it seems as video visits will continue in some capacity going forward. I don't know what it's going to be, if they're going to continue to have, state reciprocity of, applying for temporary privileges, or if there's going to be reimbursement for video visits at the same rate as an in-person. So it's all those things that were mentioned, plus all of those considerations going forward.
Yeah, and the reciprocity for, we focus a lot on what it is for independent providers, so physicians and APPs, but it also applies to really anybody licensed in our state. So our nurses, and I expect probably for UC, many patients right across the river, is it legal for your nurses for example, to be, conducting video visits with patients across the border? Where are they physically located? I know we had many, many questions about that. So Abigail, in your, with your title, what does your boss tell you? What do you need to be focusing on? You're the director of telehealth at UC Health, and so what do you need to be focusing on going forward?
So we touched on a lot of this already. Our focuses really are what we have on the screen: optimizing workflows and standard work and rolling that out. And then another one you touched on was this out-of-state licensure. I will say that states have made this very cumbersome for us. Indiana rules are different than Kentucky rules. They require different paperwork. And then, for our surgery groups who want to do outreach, then, all the other states in the surrounding area, they want to provide outreach to, they all have different rules, and how do we manage those? And so then part of the strategy is talking about at what point do we start encouraging providers just to go ahead and get full licensure across state lines to provide video visits, but we're also in limbo, like you said, are we going to be able to continue doing this, or will some of those guidelines change? And the other big focus we're working on, we also talked about, was this governance structure, and what does that look like, and how do we incorporate that into our already embedded, like MyChart steering committees, like Melissa mentioned, and our informatics committees. And since everyone has a taste of telehealth, and this has been a watershed moment for us, we're getting all new requests in for telehealth, and specifically patient monitoring in different areas. So how do we do that, or centralize it? Do we want to use one program like Premier HRS, or are we okay with several different programs? So just coming up with that governance committee or group to talk about these requests and use cases and how they're in alignment with our enterprise goals, and rolling them down is really what we're focused on right now.
And I think we've talked a lot about workflow challenges. We haven't talked a lot about, and Melissa, I'm gonna tap into you here, and as one of our last comments. What supply chain? I know that our IT colleagues were really challenged. And you mentioned the digging 100 iPods up, old iPods out of the closet, but how did you manage the challenges associated with backlogs of webcams and price gouging, quite frankly, on those sorts of things? How did you? What was your experience there?
Well, as I stated, yes, it was very difficult, in trying to get hardware in, how we needed it, when we needed it, what we needed. I honestly, we just had to go with the flow. Whatever we could get our hands on. Sometimes we would take devices maybe that were in locations and moved them somewhere else where they were needed, especially during the surge, right? Because we wanted to focus a lot too on our inpatient settings, so that we could reduce the contact between patient and provider, and then allowing our patients to be able to communicate with their loved ones. So we did actually move some equipment from an ambulatory setting, because at the time we had decreased obviously some of that scheduling on the outpatient side. So it was really just strategizing and shifting and adjusting how we could. Luckily now, obviously, one challenge we had is, we did a great job in transitioning to the Epic hosted client. But when we did that, the iPods were no longer viable devices because of their age. So in the interim, we had purchased iPads and basically did a swap out of everything that we had already deployed, which was over 100 devices, and went back out and had those iPads, swapped them out. We ordered some more. So yeah, it was quite a bit challenging, but we're even continuing now, to purchase more iPads and get those out in the area. The providers just seem to like the Canto, the bigger view of the video, than Haiku. Though they do use their sometimes their personal devices or smaller devices when they have to. So yeah, it's been very interesting from a technology perspective.
Yeah, I think we had a very similar experience, and we had some areas, our HEAM group, for example, just ordered a whole bunch of iPads because we were having a hard time getting cameras. And actually, I think we sort of encouraged the use of the Haiku Kanto just because it made them more portable. So, yeah.
Rob, this is Dory. I just have one more challenge that isn't on here, but I think is really important that occurred during the pandemic and will have some sort of impact in the future, is just disparity and parity of access for patients who have broadband, may not have the right device, and how do we address those types of things and being mindful of that going forward, of the wherever the patient is socioeconomically, that we need to be mindful of that when we're talking about telehealth.
And also, Dory, to tap onto that, how do we collect that information or find out where those disparities are? So I think that's one thing that's missing, or that we all, should come together to collect. What should we be looking for the patient experience and the patient side, and what do they need and what do they have? Even in urban settings, it's also a challenge, not just rural areas. And I think that kind of information is something we don't have entirely.
Yeah, very good points.
Yeah, I think just to kind of add on to that is the whole patient experience side of this. We've been working on developing, patient education materials, scripting for the staff, all those things to make it better for the patient. And also hopefully to sort of pick up maybe on some of those areas where we're dealing with a patient who is not going to have the internet capability or the phone that is going to work early on, and either figure out how we're going to help get that fixed, or decide this isn't, again, one of those cases that's appropriate for a telehealth visit.
Yeah, and I know at OSU there was considerable effort towards patient education and marketing on how to use their own devices to access telehealth. But I think all of us probably that challenge that Dory mentioned, and how do we get to our underserved population in a way that is helpful to them, and in most cases they're the ones who are probably in most need of the types of services that we can offer via telehealth. So I have one question here from Aaron, and his question was if we create unique video links for each provider. He had a company that has a communication hub that can send links and instructions where you can click one link to join a telehealth visit, which can reduce no-shows by 50%. So I can tell you that at OSU, if they're using one of our third-party, specifically something like UpDocs, yes, they would get a unique link. It's not really for a provider, but they would be able to send a unique link that is actually timed. So if I am the provider, I send out a link via one of my third-party applications. That link would be texted to the patient, and the patient would have a time frame, typically 10 minutes, to be able to access that link so that they could get in. It's interesting you brought up the no-show piece. That has definitely been an upside to our video visits. Those have been reduced pretty dramatically. So, any other questions from the audience for our panelists? Or any other further comments from our panelists to the audience? Either way.
I would just say I think we're all in the same boat and we all are experiencing the same challenges. So please feel free to reach out with any questions, and I think we're all happy to connect.
Yeah, thank you, Abigail. I wholeheartedly agree. I think that between this panel, and I'm going to put a plug in for our next speakers, Brooke Bellamy and Brian Mitchell, who are going to talk about our rollout of telehealth at OSU in general, not just the James. some really great experts between our organizations on how to do this. I think, we all talked about the challenges and things that have gone better, but I feel very good and very proud of our respective organizations for what we have done to continue taking care of patients, in an unprecedented time. And I think by and large, we didn't miss a beat. And that speaks to the collaboration between, internally our providers and our specialists and with our IT colleagues. And it also speaks, I think, to an organization such as ours where we have the ability to collaborate with one another across the state. So these are great things. And I'd like to, really express my thanks to Abigail, Dr. Reiling, Melissa, and Dory for participating and putting up with my questions before this, and really appreciate your time this morning on this panel. So thank you.